panelists. Welcome both, and thank you so much for talking to us today. So to kick off our discussion, our first question is, how is PCD care organised at your centre or in your country? Has this been a recent development, or are there any changes in planning?
Who would you like to kick off?
No, it's okay. You can start, Fiona.
Are you sure?
Yes.
Okay. So so I'm based in the UK, and the question, has it been? How is it organised in our country? So in our country, we have 3 centres for diagnostics care. So patients can go and be diagnosed with PCD in 3 places in the UK that are geographically spread around the country. It doesn't always work for patients to have to go. There's some patients have to go a long way, and some patients don't have to go very far. But when we set the services up, we asked the patients what they wanted, and actually what they wanted was to see someone that really knew about PCD. So they didn't mind travelling a little bit of a distance. I think the furthest someone might have to travel might be 2 or 3 hours, but all of the centres are reasonably well spaced out and easily able to get to by public transport. So we have 3 centres for diagnostics, and that was set up in, I've got this written down somewhere, in 2006, so a long time ago. So 2006, and then we had a paediatric. So now we have 4 centres for care for children and adults. So in 2012, we had a paediatric management service. And so we have 4 centres, one in Leeds and Bradford, one in Leicester, one in London at the Royal Brompton, and one on the south coast in Southampton. Now, these are geographically spread around the country, but we have one in Leeds and Bradford because we have a lot of PCD patients up there. So, we also have outreach clinics. So we have those, our clinicians go to other places in the country to see patients for their annual reviews. So again, we have people from Southampton go down to Cornwall and Devon to see patients. So patients don't all have to travel to their centres. So we have 4 centres, and then so in 2012 we had a paediatric management service, and then in 2019, not that long ago, we had an adult service. So just to recap, from 2006 to 2019 we had the full service. So one of the questions later on is how long did it take, but it takes a long time to get money out of our government. So that's what we have here. And so on our adult service, our patients can go to a multidisciplinary clinic where they see a respiratory doctor, they have their lung function done, they have any imaging they need, so they have x-rays, they have blood tests, they have sputum samples, they have access to see counsellors for fertility, they have access to see ENT surgeons, to have their hearing tested and see a surgeon, and they can access fertility people all on the same day in the same clinic. Oh, and physiotherapy. Yeah, that's the most important thing, isn't it? Physiotherapy is the most important thing. Now, that's what's supposed to happen. In reality, it doesn't always happen. So, but my son last week went for his annual review, and he did have an x-ray, he had blood tests, he saw a physiotherapist, he saw he had his lung function done, all on the same day, all within a couple of hours. And when they were children, it used to take forever because you'd have to go on separate days and things. So generally, they do get all of those access to those services all on the same day. So I think that's answered the first question. Now, are there any changes in planning? I think there are changes to try and constantly improve the service and to see that people do get to see these, but I don't think there's any major changes in planning for us. So there you go, Emilie, over to you.
Okay, thank you. So in France, there is a health network for rare respiratory disease called RespiFil. So it's not only for PCD, but it includes PCD. So it exists since 2014. and it's funded and steered by the Ministry of Health. And under this network, there are 24 reference centers for the rare respiratory diseases. So not only this, PCD again, but included PCD. So Respirare is for children and Orphalung is for the adults. So a center of reference is brings together multidisciplinary hospital skills, and it's organized around a highly specialized medical team with proven expertise in these diseases in the fields of care, research, and training. And then there are 64 competence centers in each region, so generally in a university hospital center. And the purpose of these centers is to ensure that patients are cared for and monitored as close to home as possible. All of them use a common national diagnosis and care program who was developed over the years and is published by the Haute Autorité de Santé, so the High Health Authority, since 2017. And I must say in parallel, since 2002, there are some specific centers for cystic fibrosis, partly financed by the association Vaincre la mucoviscidose, so fight against cystic fibrosis. And in reality, some PCD patients often benefit from these centers. It was my case, for example, when I was first diagnosed. And also here we have the reality. So in reality, for the patient, being monitored in a reference or a competence center is the best case scenario, as some patients are still followed by a CT pulmonologist and ENT, not based in an hospital, so not always aware of the latest development in the treatment for PCD, or not always caring if, for example, the pulmonologist doesn't know if you see an ENT and doesn't really care. And sometimes they don't know PCD. As it also happened for myself, I was treated for 15 years by a pulmonologist without knowing I had PCD. So that's it for France. Thank you.
I think there is some commonality there, actually. I think now this is my personal opinion, and it's not something that I've discussed with anybody else. But in the UK, we also have lots of cystic fibrosis centres, and we have a lot of funding associated with that. And as you will all know, there's less patients are doing so much better with cystic fibrosis. So I think at some point, our PCD centres, we're getting more and more patients diagnosed with PCD, and they could possibly be seen in the cystic fibrosis clinics. And but then that would involve making sure that all of those cystic fibrosis doctors do really understand that PCD is actually quite a serious disease, because up until now, the cystic fibrosis doctors have always thought that cystic fibrosis was worse than PCD, but there is some evidence now. I thought Marona would be able to back me up on this, that actually some of the patients are, lung function can be much worse in PCD patients. So that is possibly something going forward that might be able to utilize those resources for patients with PCD.
Yeah, it's the same thing in France. At the beginning of the year, we had a regional meeting of the association in Besançon in France, and one pulmonologist was saying that due to the new treatment for cystic fibrosis, the Kaftrio, they have less and less patients, and so they use the resources for other patients like PCD patients, but they don't know if in the long term the money will still be there or not, because as you said, there are less the patient, the cystic fibrosis patient, they may need less and less care. So we don't know what will happen, but
no, it's an interesting.
For the moment, we can access, and it's good for us.
Yes, it is. Yeah, I've just had a message from Susie, who's on the call, who's quite rightly pointed out to me that I'm talking about in England, our services have 4 centres, but in Scotland and Wales, which everybody thinks is all part. It is all part of the UK, but they're separate countries. Is that it's not as good in Scotland and Wales and Northern Ireland. And I know that the PCD Support Group are actively trying, and have been for a very long time. And Susie will know this, trying to improve the services in those countries as well. But those countries do have access to our services, but obviously they need to travel to them. So yeah, so we do need there's still work to be done in Scotland, Wales, and Northern Ireland. So, sorry, Susie. Right.
And just to read out Myrona's comment, she said, certainly in children, and especially now with the new medication for CF.
I have a follow-up question. Maybe first of all for Emilie. You mentioned that some are under those high authority centers, or the care is structured under that, and some are then cared in reference centers, or some just in private pulmonologists or ENTs. Do you know if there are any efforts or any plans to have it more centralized, or have it at least in reference centers or specialist centers, the care more specialized? Do you know any efforts planning to do that?
I'm not sure. I mean, that's also what we are advocating for in ADCP, and but I'm not sure. Last January, we were with the association in Lille. There was a congress of French-speaking pulmonologists, and we talked to a lot of them, and some of them were not really aware of PCD. You know that it's really underestimated, underdiagnosed this disease. So we would hope for this, and it's one of the recommendations we have at the end. But I don't know exactly what is being done at the central level. I mean, at the Respiratory level, and yeah.
All right, thank you.
I can inquire maybe late and give you the answer later.
Thank you. And to Fiona, you mentioned that when setting up the 3 diagnostic centers in 2006, that you asked the patients what they wanted. So
yes.
Who asked this question and directed it, and how was it all implemented? How did it all start? Who took the initiative?
So yeah, so the patient support group really took the initiative along with the clinicians. So our PCD support group was set up. I've got some dates down here. So it's a long iterative process, and it didn't just happen overnight. But basically, as patients, so when my children were diagnosed in 2001, and they were diagnosed in a research lab in the Brompton Hospital. And I'm not joking when I tell you this research badge had so much stuff in this room that you couldn't actually get to the thing to do the nasal brushings. And there was an exercise bike in the middle of the room, and there were, and I was like, this doesn't look very professional, It's like, no, I've come to see the best doctors in the world that know about PCD, and it's not very professional. But it wasn't professional because it was all done on research money, and there wasn't hardly any research money. And I was like, kind of thinking, I think this is right. Children should be diagnosed earlier. The earlier they're diagnosed, the better their prognosis. So we started at that level. But in order to do that, we had to kind of find some proof and some evidence. So we had to kind of find the clinicians that looked after these patients, find some evidence, get some papers written about some evidence on why they needed to be diagnosed early. And then we could then we had to ask our patients what they thought. So we asked the patients by emailing them and getting them to talk to us at our PCD days, and this was long before we had like Zoom. So we got them together for meetings, and we asked them, what do they want? And everyone said, we want our children to be diagnosed earlier. We want them, other children to be diagnosed earlier, because obviously our children have already been diagnosed. My son had bronchiectasis at the age of 6, so I didn't want that to happen to anybody else. So I wanted to make sure that they were diagnosed really early. And then obviously the medics can see there's benefits for that, but then the NHS, our national body that pays, could also see the benefits for that, because if you have healthier children, then they cost less money to look after. So there's benefits all the way along, but we had to build that case up, and it took years. I mean, absolute years to do that. But we did that with the support. So I've got some notes here. So we asked our members what we wanted. We identified what we needed. We asked the members what they wanted. Then we got the clinicians to support what we were asking for. We found some evidence again. So we had papers written on it. We found evidence to prove that that's why we needed the service. And then we went to our NHS and said, this is what we want. And then they wheeled out people like me to talk to the commissioners and say, this is what happened to my son, this is what happened to my children, this is how it affects us on a day-to-day basis. So there's lots of layers of evidence and information that needs to go into this, and it sort of builds it on. And we had to get things like, we didn't have PCD guidelines, so no one had written any guidelines. So if you want to run a management service, you need to have some guidelines that have been proved by loads of people to say this is what needs to happen. And unless you can got evidence to prove the guidelines, then that has no weight either. So we had to layer all of this along. And then of course we got the diagnosis done, and then we had to go back to the NHS and say, well, actually, there's no point diagnosing children if we're not looking after them properly when we've diagnosed them. So then we have to have a service for that. And then of course we look after all these children, and then Myron has asked a question about that as well. But we're diagnosing all the children, we're looking after them really, really well, and then they go into adult pulmonary respiratory clinics, and no one knows anything about PCD. So we actually need an adult service as well. So that's how it all happened, but it takes a really long time. I mean, literally, I think we started this in 1990 and 2019. So, 29 years it took for this real service to happen, with loads of people, but people like me and Carol, my predecessor, basically kept going to the clinicians and going, we need to push for this, we need to push for this, we need to push for this. And everyone kept saying to me, this will never happen. You'll never get this service. And it's like, well, we will. And we'll do it. I might die before we get it. So, but we did get it in the end. And it's not perfect, and it isn't perfect. And, we should get it for Scotland as well, and Wales and Northern Ireland. It's not perfect, but it's much, much better than what it was when my children were diagnosed. So, yeah. So, yes, but Irena asked the question about the differences between paediatric and adult care, and are they still very different? And I think they're similar, but I think, you still see all the same multidisciplinary people. Obviously, you don't see fertility people when you're children, and you still see all the same different doctors. But I think when you're a child, it's much more rigorous, and you see the doctors a lot more often, and they jump on every single exacerbation, and they did with my children, and I think that is why they're so well now. So I think because they had such a good grounding on how how to do physio, how to look after themselves, how to make sure that they could care for themselves as they grew into adulthood, and the transition from children to adults care was really good. So I think that I think children need more day-to-day care, and the parents need a lot more support as well. So I think that's why the service for the children is so much more, I don't know what the word is, but just more, there's more of it as children, so, and less of it as adults, unless you're particularly unwell. But my children probably go once a year now. So, and when they were children, they probably go 4 or 5 times a year if they were well, and they were never well. So, but they're well now. So, and I think that's because of how well they were looked after as children. But again, thanks to all of your work, there's a lot more evidence now to show that if you have, the different types of genotypes and phenotypes. So if you have a particular gene, and you know that if you, so my children have got DNH5, which means they get particularly bad lung disease, but the other things are pretty mild. So we've concentrated on the lung disease, keeping their lungs as well as possible and jumping on every single exacerbation when they were small, and now they're doing quite well. So, but we're learning that now as we go along. So I think there'll be a lot more personalised medicine probably in these services for these patients, that some of them don't need to come to clinic all the time and have a lung function taken because they're not so bad, but their ears and noses and sinuses are dreadful, and they manage, those are the things that cause them the most grief. So I don't know. You're the experts on that, Myrona. Does that answer your question? Yeah.
If I can add on this, so it's the same thing in France. Children usually, first of all, they are diagnosed quite early, especially the one who have situs inversus, the inversion of the organs. And also one mother of our association, she told me that her son, who is 5, he goes 2 times per year, so every 6 months, to have a whole day of examination with all the disciplinary, and then he goes to the pulmonologist in between. So you can see the pulmonologist at least 4 times per year. As for adults, usually it's 2 times per year, every 6 months, and maybe more if we have an exacerbation. But the regular regular consultation are twice per year.
I have a question about, so we speak about these paediatric and adult services. Are there any transition programs in place to help with that journey of going from your paediatric team to an adult team?
Go on.
So in France, they are working on it. So several hospitals in Paris, they have started to work on it, and I think it's almost finalized. So they are experimenting it. So it should be on soon, but not yet.
Yeah, in the UK, there is a program now. Again, Myrona, you might correct me if I got this wrong, but I think it's called Ready, Steady, Go. Yeah, and where patients go from quite a young age, actually, from probably 9 or 10. I think you and Gregor were probably late into the process, but where they're encouraged to go and see the doctors on their own, without their parents, leaving their parents in the waiting room, and to discuss their issues and to learn to go and see the physiotherapist on their own. And they learn. And they check to see whether they really understand what PCD is and what the implications of not looking after themselves are. And they start that quite early on, like 8 or 9, and then until they're about 16, where they leave the services. So they tend to leave in the UK about when they're 16, 17, because the paediatricians don't like their patients to be taller than them, I think. So yeah, or one of the doctors said he didn't like his patient having more hair on his face than he did. So yeah, I think but they learn about, so they learn all of the things that my children, when they were young, they never asked any questions about but because I was their mum, obviously they had to learn about PCD. So and they got involved in doing things for the PCD support groups, like talking about it for videos and all sorts of things. And like Susie's on here, and her daughter's done exactly the same. So we're talking about our children and getting our children to get involved. So they did know a lot about things, but you're never sure what's gone in, and things like talking about fertility and things. A 17-year-old boy doesn't want to talk to his mum about that. So it's great if it's talked about within the transition program, so that when they go to adulthood, it's not all a big surprise for them. But when they go to, the difference here with the adults and children is that the adult services think that the children have been really well looked after, and probably too well looked after. And when they go into this adults, they're not that responsible for looking after themselves. But I think that's because of the Ready, Steady, Go program. They're much better now. So, but yeah, so we do have I think it's really good. So yeah, we do have one.
Right. Thank you both very much. We have another question from Tamuna. Can I ask why adults see pulmonologists 2 times a year and children 4 times a year? Adults have more damaged lungs, so why is there a difference in seeing a doctor? Well, I think just as Fiona implied already, children are still growing, so are the lungs. So we'd like to make sure the lungs are growing as healthily as possible along with the children. And also adults are adults, so they are responsible for themselves. They're not growing as much anymore. And so it's more like this typical adult care of, look, this is what you're doing, what we recommend you to do anyway. If you're doing or not, well, it's up to you. So this is the typical adult care, and there's the difference between pediatric and adult.
Yeah, and maybe, I mean, when you're an adult, you can take your antibiotics when you know you have an exacerbation. You don't have to go to see the pulmonologist, you know you have to take them.
Yeah, I think yeah, there's a lot more of self-care when you're an adult. So, you know, and I'm sure Emilie does this herself, but you know, my children, I've often talked to my younger son particularly, and I'll say, oh, your cough doesn't sound very good, and he'll say, oh yeah, I've started some antibiotics. It's like, oh good, but have you done a sputum sample? Oh no, because that's a bit of a faff. And so yeah, so yes, he does do it, but normally he does it about a week probably later than he needs to do it, and then he's very surprised that the antibiotics that he's taking don't quite weren't the ones he needed. But anyway, he yeah, so although they've been very well trained and have all the information, they still don't get it right. So but yeah, they're very well. So okay, you've got some more questions. Myrona's written about do we have access to dietitians or psychologists? So yes, children do have access to dietitians and psychologists, and they would be referred to from their pediatric care MDT. So yes, they do. Yeah, my children saw dietitians before, to be honest, before the PCD service was in place. So and I'm sure Gregor wouldn't mind me telling you this, he's accessed the adult psychology service as well, and found it really useful. And he actually went to his GP and saw a psychologist through his GP, and didn't really get on very well with them. And I suggested that he go back to the PCD service and see if there's somebody there that could help him, that could understand living with chronic conditions. I don't think that was what the issues were about, but I don't know, because he didn't tell me, but he did tell me he'd seen somebody, and he said that this person was really helpful, and that was through the service. So yeah.
And in France, in the reference or competence center, no, there's no psychologist. So that is one of the requests we are when the question will come about which department should be included, or we think that yes, psychologist for the patient and also for the families, for their families should be offered, because it's sometimes very needed. Yeah.
Yeah, and I don't think that is part of our paediatric service, and I think actually that is probably something that could be improved on, is the having some psychological help for the parents. So it's you know, I have first-hand experience of how hard it is, particularly when you have 2 children with PCD. We were very lucky; we had 2 of them. So okay.
So
what next?
You've spoken a bit there about the different departments that are included. If you could both just expand on that, please, and tell us all of the departments that are included. And you mentioned some of the ones that you think should be included or offered. And you've also touched upon who's in charge of scheduling these different appointments with different specialists. Do you think this could be streamlined, or what improvements do you think could be made?
Yeah, so our children see a respiratory physiologists, I think they're called. Are they the people that take the lung functions? They see a respiratory doctor. They have access to a respiratory nurse. So they have physiotherapists, ENT surgeons, hearing test people, whatever, the audiologists are they called? Yeah. Getting me to think about this, aren't you? And dietitians and psychologists, not sure there's, oh, and then obviously they have access to radiologists because they have people take the imaging, and then they probably have, and also blood tests and things, but that will happen all within the clinic. So, and in the UK, that's all organised by the PCD team, and they have a PCD administrator that will organise all of those, and preferably all on the same day. So they generally see all of those people on the same day when they come for their annual review. So, which is quite a feat, I think. So getting it all done. So I think in the adult services, they see most of those people on the same day, but they also have access to the fertility clinics as well. But then that's a separate referral because not everybody needs to know about fertility every time they go every year. So that's a one-off, I think. So, but other than that, but it's all organised by a central administration team, and the patients and the patient support groups don't have anything to do with it. But I know there's other services in the UK where the actual patient support groups, for instance, Ulstrom syndrome, which is a rare genetic condition caused by cilia, and also the BBS, Bardet-Biedl syndrome, they have services and they run all the clinics themselves. They organise all of the clinics and things. So there's different ways of doing it, but in the UK, we decided that actually we didn't think that was our job, and particularly as all of us are volunteers, so none of us get paid to do the PCD work that we've done over the last 20 odd years. So yeah, so none of us got paid, so we decided that we wouldn't do a clinic. And also I think there's risk associated with that if you become involved with the patients on a organising their care. So we didn't do that, but other people do. So there are different models, so it might be worth talking to them about how they, and if you wanted to do that as part of your research with more, I can put you in contact with the people that run those services. But that's how we do it here.
So in France, so usually you have the pulmonology, so which department are included in the reference center. So usually at least pulmonology and physiotherapy. And of course, when we go, usually it's, in one day, we try to have the X-ray or CT scan, the lung function test, sputum sample, and sometimes blood test, not every time. And exceptionally in some center you have a sport educator, which is great. But the ENT, they are not in the same center. You have to see separately pulmonologist and an ENT. So in certain cases also patients like children, they have access to other departments such as gastroenterology. We have here, a child of 5 years old who has oral trouble and trouble eating. So he benefits from a consultation with a gastroenterologist. So which department we think should be included? So sport educator, it should be systematic because it's, also a good part of our treatment to do some sport or at least physical activities. Someone suggested also that we could see a gynecologist, so it's also linked to fertility, of course. And we mentioned already that psychology consultation should be also offered for patients as well as for their families. And for scheduling our appointments, we are pretty much on our own as an adult, for the coordination of all these appointments. So usually we take appointments ourselves from one appointment to the other. And as we say, 2 appointments per year in general. and more for children. And also to be noted that we always have difficulties to find good physiotherapists for airway clearance. It's really not easy to find a very good one, you know, specialized in airway clearance with the right method, because we are very difficult. We want to have the right method. So this is, yeah, quite difficult to find. So, yeah.
While Emilie's been talking, I've thought about 3 other departments that we access as well. So yeah, so at gastro, some children do have gastro issues, so particularly little ones, and they have to have pegs put in their bellies and things. But I don't think it's routinely offered. It's but you would access them. We have cardiologists check young children. So when they're small, they get checked for any heart defects. So if they haven't got any, I don't think they go look at them again, but they do check them at least once when they're small. And then the other thing that's really important for our families is to have access to genetic counselling. So for planning their future families, if they've already got one child with PCD. But I always forget that, because again, I had 2 children when mine were both diagnosed at the same time virtually. So we never had to go through that for our children. But saying that, I have accessed them for other things since then. So they always love to see us because we're a genetic mismatch, our family. So lots of genetic conditions going on in our family. So yes, I have seen one, but I haven't seen one about having more children with PCD because I'm too old now. So yeah. But I think it should be included in your super service. So.
I'll just read out Marona's comment. In many other countries, people with PCD have to organise themselves their referral appointments, which leads to a great burden.
Indeed.
Okay. Sometimes even for physio, Marona says.
And what is strange also is that sometimes, so even after I was diagnosed, the pulmonologist would not ask me if I would see an ENT, and he did for a few years. I haven't seen an ENT because I was just washing my sinuses and putting the medicine, and I thought it was okay, but finally, no, it was not okay. But the pulmonologist did not ask me, are you seeing an ENT regularly? So, I mean, they should also, I mean, it's really like the pulmonologists, they look only at the lungs, the ENT only as the sinuses, and it's a whole package. So they should also at least ask us if we do take care of the other part of our body affected by PCD.
Yeah.
Right, thank you both. Just one short follow-up question from me to Fiona. So for the adults, is it also still the centralized care that they don't have to schedule anything, or is it just for pediatric care?
No, it's for adults as well. Yeah, we have administrators that sort it out. Yeah,
that's really great.
Yeah, and also they're very efficient apparently, because my eldest son moved house and all sorts, and they sent him a letter and he'd not told them he'd moved house, and he turned up for his clinic a couple of weeks ago and they said to him, how did you, and he said, oh, I've changed house and everything else, and how did you find me, how did you know to come? And he said, oh, you sent me a text message, so I knew to come. So that's how the system works. So he was like, oh yeah, I just didn't tell them I'd moved house. Okay.
That's excellent.
Yeah.
So no chance for loss to follow up then.
Exactly. Yeah. So.
Tamuna says, we are just starting out, meaning guidelines, official patient organization, etc. It's very informative to listen to both of you. Well, that's great. And Hans Ordi is asking, who gave the inputs to establish PCD centers in France or England? Who took the initiative?
I think it kind of relates to this second question that we didn't we haven't seen yet. And so in France, so the question was who was involved in setting up current PCD care. So I don't have the full reply, but we know that some physicians, such as Estelle Escudier, who deals with medical genetics and embryology, she worked a lot on PCD since 2001. And so as far as we know, it has taken almost 20 years to develop a good management of PCD, as well as to standardize diagnosis and care in the fields of pneumology and ENT. So yeah, it took a lot of time, and sometimes it's also because of one personality. I mean, one doctor who really put a lot of effort in this. I mean, several of them, but.
Yeah, I think that is the same in the UK. There was a core of doctors that pushed for this service. So the Brompton and Southampton and Leicester, really all the three centres, the diagnostic centres, really pushed for this service because they could see the benefits for the patients, but they could also see the benefits for their research. Obviously the benefits for the patients, but the spin-offs is that they were able to do more research. Because we've got all these patients all going to the same things, we can start to really understand better how PCD progresses, and there is a lot of cross-fertilization between the three centres, or the 3 or 4 centres. So they all regularly meet and they discuss difficult cases, how they manage them, and how the changes in diagnostics have developed, and the different ideas in care. So there's loads of benefits for the patients on a day-to-day, one-to-one basis, but then there's loads of side effects as well, that they're learning so much more because they've got all the patients in the same place. So I think but I think it's basically, it was pushed along by our support group, but there's some real key coalitions that we got really excited about the benefits they could see for their own personal development and their own personal gains. So yeah, I hope that makes sense. Does that make sense?
Yes, it does.
Yeah.
Thank you. Now, our next question. What do you think should or can be improved in multidisciplinary care in PCD? So next to all those departments that you already listed, what do you think is missing? Maybe it doesn't have to be on a regular basis, maybe just as a baseline checkup, or what do you think is still missing in multidisciplinary care in PCD, and where do you think should we start to make those changes?
So if I can start. So we think that patient education should be offered systematically with a specific patient education protocol that would serve as a reference. So this would also enable a more holistic approach of our disease, and have a better impact on our quality of life. And also, for example, when I was diagnosed, I was already an adult, and I guess that when you are diagnosed as a child, the doctor explained to you a lot of things about breathing, but I don't know. But as an adult, they don't. Maybe they think you already know, but sometimes you don't know. So to have a patient education protocol would be a real important thing to do for children, and for children and also for adults, so we can also understand better and know what to do exactly. Also to take our medicine, to take the les aérosols, the aerosols.
Later.
Yes, inhalator. I mean, all these kind of little things that you have to discover bit by bit when you talk to someone, or you talk to a new physiotherapist that explains something, or to another patient. You have to find yourself everything or about all this. So patient education is really very important. Then, of course, we mentioned a bit about fertility. We think also this should be also discussed, but maybe in a nuanced way, because not all PCD patients are infertile. For example, I had 2 children naturally on my own. I mean, with no treatment. So you should not scare people with this, but it should be discussed, and you should, when you have a certain age, you should have a fertility consultation to know where you stand. We also think that the ENT should also take care of anosmia, which is really set aside because it's, I guess for them it's not a big deal, but it's really responsible for a degraded quality of life. It seems that it's not really recognized by the physicians, but it's really important for our life. So most of us, when we were a child, we would not have this problem. But then growing up, and maybe, I think with the polyps and everything, we became anosmic, but it is not always, I mean, it's not taken care of. I don't know why, but it should be. Then we mentioned already genetic counseling. It's also rarely proposed, but it would be very important, especially to inform the parents of children with PCD. They usually have a lot of questions and a lot of fears. Then we are, in France at least, we are also missing information on nutrition. And maybe also an appointment with an infectiologist or bacteriologist could be proposed, because we are very impacted by different bacteria, viruses or fungi, and we have very few information about them. We don't know exactly who they, I mean, what kind of bacteria, virus or fungi we could get, how can we, I mean, how do they impact us, how to avoid them, what are the treatments, what research are going on these different bacteria. So it could also be interesting to have an appointment with such a specialist. And we think to make the change, the most important would be patient education, because it would make a real difference for us. And also, as we said, all patients should be directed to reference centers, because, as I mentioned, we are not all followed in these centers. And then, spreading the information on the existing centers among the doctors, the private pulmonologists, for example, and the patients. And also, we feel that coordination by a specific specialized nurse would be also useful, also to better coordinate the different services, the different appointments, and also coordinate with the family doctor, who is also involved, especially especially for children. So I don't know if I was clear, but yeah, that's all the ideas we have. Thank you.
Thank you. Thank you, Emilie. Those are very good ideas. Also answering where to start, and exactly, all of these are certainly very much needed. Yeah. Fiona, do you want to?
I think yeah, I agree that patient education is really important, but I think as children, the parents are educated along the way, but they're not always in a position to take it in. So, which is why the support groups are very good for doing presentations and learning more about it, and doing Zoom calls and things, and learning about different types of research and things. So I think that's really important education. But as you were saying, Emilie, when you get diagnosed as an adult, you have all of this information come into you, and I mean, I just go on my own personal experiences, but when you're told there's something wrong with you, you only take some of it in, and sometimes you have to have it drip fed to you, so you can't take it in all at once because it's all too much information. So there's, it's being able to access that information when you need it. And I think that's one of the difficulties, is that you don't know you need it. So, you learn it, but you don't necessarily you don't know. So it's difficult to get it at the right timing for people. But if you can have it accessible on websites and videos and lots of different ways that are accessible to everybody in the ways that they can disseminate it, I think it's useful. So I think education is important. But the other thing I think that our patients, so we're going back to this business of how well you get looked after as the children. So my children, when they were small, used to have IV antibiotics quite a lot, and we used to do them at home. And so I used to do them, and they had porta caths fitted, and we used to do home IVs, and that was really easy and it worked really well. But I know that some of our adults have found that's really difficult to access that service. So if you become unwell when you're an adult, you have to go into hospital. And so and I think that, you know, when you've had that all the way through your life, and then when you become a young adult, you can't access that. I think it's very annoying to some of my patients. And you know, what we're trying to do is keep people well and out of hospital, and if they can have access to those services at home and they can look after themselves, I think that's much better. And we all know that you sleep much better if you're in your own bed. So, you know, if my children, if they came home and had home IVs, they would get better food, because the hospital food, although it was supposed to be the best in the UK, was still revolting. Yeah, hospital food is not good. You don't sleep very well in hospital because people are poking you, checking you're still alive in the middle of the night. So, you know, if you sleep in your own bed and you have IVs at home, that's really good. So I think we need to try and, in an ideal world, have more services that are set up for those patients, and they're a bit more you know, agile, I think is the word. So for some patients have to be in hospital because they're very unwell and they can't access those services because of personal circumstances, but a lot of patients, they do work. And you know, if we can be a bit more flexible on how we look after patients and a bit more responsive to their needs, I think we'd save money in the NHS, and also we'd have better outcomes for patients. So, but I don't think there's anything else I can add to how it would work. So, does that all make sense?
Yes, absolutely.
Okay.
Thank you. Just another follow-up question from my side. Among all those department specialists that you both mentioned, I think I wonder whether it exists in your country or whether you think would be useful is, what about social services? So for example, here anyway, in Switzerland, social services are in charge of checking if you have any financial burden, or if you have to deal with any disputes with insurances. They can also reimburse for trip fares from and to hospitals, which of course can be quite many per year, or any kind of official communication with institutes. So does that exist in your country? Or if not, do you think that would be helpful?
Yes, in fact, I forgot to mention that, yes, it would be very helpful, and also to help with the administration, with the, you know, in France, I guess it's the same in UK, you can be recognized as a handicapped person and get an allocation. And this is quite complicated, and you are not treated the same depending on where you live in France, so it's not normal. And yes, this kind of counseling would be very, very important also for patients. And with the association, we pay for consultation of our members for a person like that, but it should be offered in the centers. Yes, indeed.
Yeah, I think in the UK, I think for children, I think some of the nurses help the patients, the parents fill out some of the forms and recommend that they can get access to money from our government. But I know but most of the help that people get are through the support group. So the support group help people pay to fill out the forms. And I know that the PCD support group now here in the UK, they pay someone to help people fill out the forms. The forms are very complicated, and they're complicated for a reason, really, to stop people claiming for things where they shouldn't be claiming for things. But it's very difficult as a parent or an adult to look at. You have to put what your worst case scenario is. So how do you feel on the worst day? And also you get used to doing certain things. So you kind of you just assume that everybody has to give their children physiotherapy every morning, because you forget that that's not normal, because it becomes your normal life. So there's some things that you do, like, you know, I'm sure that everybody, you know, this example, everybody has got PCD, has got boxes of tissues in every single room in their house. So, you know, people with PCD use lots of tissues. So there's those sorts of things that you just kind of assume that that's normal, and actually no, it's not normal. So yeah, so I think, but yeah, social services in the UK are not really very helpful with things like this. There are other organisations that can help you, but no one understands PCD very well. So really, it's your nurse that will help you fill out these forms, or your PCD support group will help you. So yeah.
Right. Thank you both for
Okay.
answering that question. Then we have some questions from Fiona, which Katie will address first.
Yes, if we start with something that I find amazing in organisation of PCD care in England is that members of the team might go to schools and discuss with the teachers about what the diagnosis means for the child. Maybe Fiona could tell us something more about that. I'm not sure if this exists in other countries.
So yeah, they do. When your child gets diagnosed, they go into the schools to talk about them, to talk about it, and they talk about infection control and why the child might be off school for a certain period. So my children used to be off school for like 2 or 3 weeks at a time, and it's really difficult when they're off school. They miss a lot of education, and the school has to pick that up. But when they go back, they're fine. So they go back and they're like, they're not unwell, they're just go back as normal, and they go back in, but everything's changed at school. So their relationships change. Children fall out with friends, and 1 week they're good friends, and someone disappears for 3 weeks and there's another little clique, and it's difficult for them on the social side. And the schools are really good if they understand that what might happen and why it might happen. And I mean, my children used to be sick a lot, physically sick, but if you're sick in the UK, you're not allowed to go to school back for 3 days or something afterwards, in case you've got some norovirus or something. But they never had that. They were just being PCD sick. So, but it's good for the school to be on board, so they understand. So when my children started senior school, they used to go and they had a school nurse. Not every school in the UK has a school nurse, but they used to go and see the school nurse every single day for 2 weeks. And she said, oh, they hate coming to see me. It's like, and she said, but I want to see what they're like when they're well. So she said, so when they're not well, I really know they're not well. So they used to go every day and have a little chat with her and build a relationship with her, so that when they really weren't very well, she knew they weren't very well. And so she'd ring me up and say, oh, they've come down to the sick bay and they're really not very well. And, I've never seen you like this before. So so that was quite good. But yeah, so but the schools are, it's very vitally important that the school knows, we're going back to like exercise, that they are allowed to exercise, and actually coughing is good. So coughing is a good thing when you've got PCD, because it means you're getting your lungs working. And but a lot of people would say, well, actually they shouldn't be coughing, and they're coughing loads, and that's not good. So a bit of education of the school is really helpful. So yes, that does happen. So in the UK. And it would be great if it happened everywhere. So, how about in France?
No, I think in France, no, the PCD team, they don't do that. It's up to the parents to do that. And sometimes the children themselves, they prepare a presentation for the school, for their classmates, to explain. But it's on the parents and the children to do that.
Thank you both. Another question for Marona. There are some physicians mainly caring for adult patients who still insist that since there are no real treatments for PCD, it does not matter that PCD patients are seen in specialist clinics. I would really like to hear your opinions.
Well, I think we should shoot them all, Marona. Yeah. They, yeah, we've spent I remember having conversations we have, Emilie was talking about the Association of French Physicians in Lille. So we have a similar thing in London once a year in the British Thoracic Society. And I have spoken to so many doctors about PCD there, and they're saying, oh, well, it's the same as cystic fibrosis, or it's not as bad as cystic fibrosis. And it's like, No, it is. It's worse, and giving them the evidence. So yes, there are still a lot of doctors that are like that, and which is why, you know, it's not the education; it's the education of the parents and schools, but it's also educating the doctors, and still, which is why, you know, when you and Gregor were diagnosed, there was hardly any research into PCD, and now there's so much, and there is great organisations like BEAT-PCD, which is really spreading the word and doing lots of translational longitudinal studies about PCD. And I think the more evidence we've got to show these doctors that actually it is a serious disease and it does need to be managed properly. But again, if we have patients that know it is, and then they can tell the doctors, then that also helps. So we need to come from the support groups, but also from the patients themselves, and saying, well, actually, this is what I want. And I think the younger generation, you know, our PCD support group is now run by young people. I'm the old guard here, you know, but it's run by young people, and they know what they want, and they're asking for what they want, and I think that's great. And you know, they will tell these doctors what they want and why they want it. So I think yeah, but there are still quite a few that don't believe it, but I've converted some of them. So, you know, yeah. In fact, Ewan went to clinic the other day, and he said, oh, there was a medical student in there, mum. And I said, oh, was that okay? And he went, well, it was fine. He said the doctor kept on telling them about how wonderful you were. And at one point I had to say, excuse me, but this is about me today, not about my mum. So, but, you know, so that's good, you know, that they're still trying it. And he was one of the doctors that he needed to be convinced. So, yeah, so that's good. So.
That's wonderful. Change is happening indeed. What about you, Emilie? What do you think?
No, I completely agree with what Fiona said. And also when I was not yet diagnosed, but followed by a pulmonologist, a private one, for example, well, he knew I had bronchiectasis, so I had a problem. And for example, he never made a sputum sample, an examination of a sputum sample. So I have Pseudomonas, I think, for, I don't know, 20 years, I don't know. And I cannot get rid of it because he never tried to see if I had something bad in my lungs. And I mean, what kind of, that's why you need PCD specialists. I mean, they know it's important. They know you have to do this. They know you have to fight Pseudomonas and all this. So yeah, I think it's very important.
Yes, indeed. Very important. Thank you both for your comments and replies on that. We have one commenter question from Hans Woody. If I think, what about PCD center in the Children's Hospital in Zurich in the future? Wink, wink. Well, yeah, Hans Woody, I think we talked about centers in Switzerland in general, right? I think centralized care is still one of the aims in Switzerland. However, right now I don't see it happening in the near future in Switzerland anyway, neither for the children nor for the adults. I think what is promising, last week we actually had the Swiss Pulmonology Congress in Switzerland. I think it was a good development of actually having more pulmonologists attending our session talking about PCD research compared to other years where there were hardly any, which also showed the lack of interest in PCD. But I think, especially the past 2 years, actually, certainly all pediatric pulmonologists that attended the Congress also attended the PCD research session. And I think this is already a good improvement. Yeah. So if there aren't any other questions or comments, we'd like to close the session.
Just like to say a massive thank you to our two expert speakers. It's been a real pleasure having you today and hearing your experiences, and thank you for everything you've done for PCD. And we'd love to hear your feedback. So please do either scan the QR code or follow the link that Yinting has kindly popped into the chat. It should just take a couple of moments to fill out.
Okay, you're very welcome. Anytime, you know where I am.
Thank you.
Okay, and nice to meet you, Emilie. We need to contact each other and have a proper chat.
Sure.
Okay.
And I hope it will be useful, and we will look forward for the improvement of all of this.
Yeah. Okay. All right.
Thank you very much.
Okay,
Fiona
you're
and Emilie.
welcome. Good luck. Take
Thank
care.
Bye.
You too.
Bye.
Bye.
Bye.